All right. Thank you, everyone, for joining us tonight. My name is Shadi Reyes. I'm a Cath Lab Director at Detroit Medical Center. I'm privileged to be with Dr. Kenton Zehr. He's our Executive Director for Cardiovascular Service Line at the Detroit Medical Center. We're coming to you every fourth Thursday with a webinar related to cardiovascular interventions or treatments and new technologies. This webinar is meant for healthcare professionals, nurses, nurse practitioners, perfusionists, physician, primary care, any specialties, to cover a lot of topics related to cardiovascular disease. So this webinar comes every fourth Thursday at 7 p.m. I'm the host and Dr. Zehr is the co-host, but today he's our guest speaker as well to talk about a topic related to near and dear to him, which is the ECMO, development of the program of ECMO in health system. How is it important, the indication of it, how to launch it, and what are the pitfalls as well. With that, we're going to start with a video introduction of this webinar. We're coming to you live from Detroit Medical Center.
It weighs less than 1% of our body mass and is an engine that never stops, pumping almost 2,000 gallons of blood along 60,000 miles of blood vessels every day. Our hearts perform like nothing under the sun. So when your heart needs care, you want a team of experts, board-certified heart and vascular surgeons with over 40 years of combined surgical experience, trained at some of the nation's top institutions, like Johns Hopkins University and Mayo Clinic. True specialists in the fields of non-invasive cardiology, interventional cardiology, cardiac electrophysiology, cardiothoracic surgery, and vascular surgery. For over 3 decades, our specialists have been available in Commerce and Detroit because we believe heart care isn't something you wait for. DMC Medical Group, trusted by the hearts of Metro Detroit.
Again, welcome again to our webinar. I would like to remind everybody this is a 1-hour CME activity. Thanks to Shirley Alvarado and Elise Bennett for putting this CME activity together. With no further ado, Dr. Zehr, please go ahead and share your screen.
Good evening, everybody. Tonight I'm going to chat about establishing an ECMO program. Now, ECMO stands for extracorporeal membrane oxygenation. Basically, it just means an artificial lung. But it also, depending on how we put the pipes in, the cannula, we can also support the heart as well. So you can think of it like a heart-lung machine at the bedside. This service is reserved for patients who have no other options. Their lungs don't work, or their heart and lungs don't work, or just their heart doesn't work. And otherwise they would die unless we put them on this support. And then most importantly, take care of them while they're on it. And lastly, get them off. And I'll present how we go about starting our program, and the fact that it is a team that makes this happen. It's not just one individual person, and it's not just the surgeons. I have no disclosures. John Gibbon, this machine you see, is the first heart-lung machine. And John Gibbon saw a woman die of a pulmonary embolus when he was a medical student. And it became one of his lifelong objectives to figure out how you could put on a person on cardiopulmonary support while you took out a pulmonary embolus. He did 5 cases, only 1 lived. He became discouraged and didn't do more, but John Kirkland at the Mayo Clinic recognized the potential. And he took the machine and he modified it, and they called it the Mayo Gibbon machine. And he proceeded to do heart surgery with it. And I'm not going to go into the details. That's subject of another talk. But that spun over into, what if you could take this same heart-lung machine, put it at the bedside, and oxygenate a patient that lungs didn't work? This is 1972. This is J.D. Hill. This is the first successful adult ECMO. What's so shocking that it even worked and the patient lived was that oxygenator that you see is on the left there. It's the size of a 55-gallon drum in diameter. It takes 50 units of blood to prime. Not practical at all, but the patient lived and ECMO was started. This is the first ECMO for a post-cardiotomy heart failure. The patient was a congenital heart patient, had a mustard procedure, couldn't come off pump. And they put the patient on ECMO at the bedside. And on the right, you see the flow chart, just looking at how things improved, how the bypass flow was increased, how the arterial pressure came up. And the patient was on for 30 hours. 30 some hours, and was able to be successfully weaned. Now, this is the first ECMO for neonatal respiratory failure. It was for meconium lungs. Lungs didn't work. And this was 1975. And she went on, one slide prior to that. On the right, you see the oxygenator. Now it's the size of a car battery. The pump is on the bottom, the oxygenator is on the top. So already in 3 years, there was significant improvement in the oxygenators. And this patient was on for almost 2 weeks before she was successfully weaned, and weaned to the point where she became an adult. And this is her as an adult. So ECMO was launched, and this was primarily launched in one place. And that was by this guy. This is the University of Michigan, Bob Bartlett. We call him the father of ECMO. No one else in the country was doing ECMO. And Bob Bartlett persisted at it despite high mortalities. And he published his first 1,000 ECMO cases in the New England Journal in 2000. Now, if you look at the breakdown, by far the majority are neonatal and pediatric, very, very few adult cardiac, and there's reasons for that. We could not get the adult cardiac patients to live. We didn't have oxygenators that the adult body could tolerate. And in fact, if you look at just the adults that are circled there, you can see their survivals. The survival for using ECMO for respiratory failure was 56%, so roughly half. But it was even less for those that had cardiac failure and they had full support for both the heart and the lungs. We'll talk a little bit about what that means later. And the survivals were only 33%. And really, the reason patients didn't survive was there was an enormous complication profile, just enormous. We still see that, and our numbers have not improved that much from what those initial numbers are, and you'll see what they are later. But you can see, just running the list on the left-hand side, you see intracranial hemorrhage. There were 4 patients out of the 59, and only 1 survived of those. And they're squared off there where you can see the adult population. You can see if you have a complication, then your survival drops dramatically. So the whole point of ECMO is the team involved and the vigilance that it takes to avoid these complications for a very long period of time. We'll talk a little bit more about that later too. Now, one of the ways surgeons are good at pushing things, because we do not like to have our patients not survive. So when you have a patient on the table and you cannot come off pump, the old days, and even in my experience, was that you had that very, very long walk to the waiting room where you told the family you could not separate from bypass and the patient was going to die on the table. Well, that happened more times than I can remember. And now there's an option for a possibility of survival, and that's ECMO. So Nick Spadera published, along with Toby Cosgrove, published their experience from patients that could not be weaned from cardiopulmonary bypass that they thought might have a chance with an ECMO support over a period of time. And they had 202 patients in the series. And you see the survival is not very good. It's 38%. Now, even some of them actually lived because they actually had the ability to put them on artificial hearts and even transplant them. So they're able to get them to a survival mode, despite the fact that they couldn't make it with their own heart. But what I want to point out is that once you get out, if you lived, look at the survival curve out to 5 years. If you managed to survive that initial insult, there was no drop off. You were alive 5 years later. So those 38% that had 30-day survival, those patients ended up being 38% 5-year survival pretty much. So that was kind of, it's the stick-to-itness of these programs that really got ECMO started. There were a few other things that needed to happen, and I'll point those out. Now, this is the very largest series that's ever been published of post-cardiotomy patients put on ECMO, 517 out of Fred Moore's group in Leipzig, Germany. Very large service line. They were doing like 4,000 open hearts a year. Their survivals were less. They were only 24.8%, so only 1 in 4. But it's 28% more than it would have, or 25% more than it would have been. But again, I want to point out the curve on the right. Once you got past that initial, if you survived ECMO, you could live 10 years later. So most of those 25% made it out 10 years. So it's all about managing the initial insult and can you manage the complications on ECMO? Now, ECMO, for what we now think it more commonly for respiratory failure, has a little bit of a different story. And that story is very similar to the COVID story. It was a similar coronavirus, but we called it a different name. It was called H1N1. That happened in 2009. Not as many people died, and it's long since forgotten, but we in medicine know it very, very well. And in the UK, they took 180 patients from 68 centers, and they randomized ones to ECMO versus ones to conventional ventilation. Their hearts were working okay. They just didn't have lungs that worked. And here's the curve. On the top, you see the ECMO survivors. On the bottom, you see the conventional management. And in lay terms, what that works out to is there's 1 extra survivor for every 6 patients. So this clearly showed that ECMO has utility in patients that have viral diseases of their lungs when they can't survive from those diseases. And indeed, this is a newer study in 2018 looking at patients with all comers with respiratory distress syndrome, and the survival curves are relatively the same. The mortality at the end of it all in the control group was about 60%, in the ECMO group was 44%. So they had 65% survival. So it's about the same as a Caesar trial. So ECMO is here to stay, but we must choose our patients wisely. And I'm going to talk a little bit about, this is the curve. And as you remember from the Caesar trial, this curve is roughly the same. About 1 out of every 6 or 7 patients that if you use ECMO for them instead of conventional ventilation, you'll have an extra survivor. So the general guideline of ECMO is if you think there's going to be a 50% or more mortality due to their cardiopulmonary failure, either pulmonary or cardiac or both, with conventional therapy in the setting of a brain that works, intact neurological status, and perceived organ reversibility, kidneys, liver, hematological, everything else, or maybe there's a suitable endpoint of an artificial heart or an artificial ventricular assist device or transplantation, we consider those patients for ECMO. So the indications on the pulmonary side are adult respiratory distress syndrome, number 1. Number 2 are the pneumonias. And the last one that we just got through, the viral pneumonias, H1N1, COVID-19. Then there's other ones like, I'm talking primarily for adults here. Aspiration is much more common for infants, but we see aspiration in drug addicts, patients that aspirate like that. We put patients on for status asthmaticus. And also more rare in transplant centers, we put patients on that need a bridge to lung transplant or primary graft failure after a lung transplant when the lung needs time to recover, the donor lung, that is. Now, on the cardiac side, by far the largest reason is acute myocardial infarction with cardiogenic shock. A patient that presents to the cath lab in dire straits that needs more support than just the Impella devices, which are temporary VADs. Decompensated heart failure with cardiogenic shock, drug overdoses, postpartum cardiomyopathy, then patients that we can't get off the pump in the operating room. And then lastly, again, patients that have dysfunction of a heart transplant like acute rejection, we'll put on, let them recover, and frequently they can recover and continue to live with their transplanted heart. Now, there are also combined reasons that we put them on. combined cardiac and pulmonary failure, like post-cardiotomy patients that have gotten too much fluid in the OR, patients with pulmonary hypertension and right ventricular failure, massive pulmonary emboli, where you can't get blood through the lungs and the right heart fails. Then resuscitation from cardiopulmonary arrests. Often the lungs take a significant hit. Drug overdose, and here in Detroit, the northern climates, we see patients that are hypothermic that come in off the street. Their hearts and lungs don't work well. We can put them on pump for a few hours sometimes even to warm them up, reboot their systems, and they can live. And there's quite a few publications of hypothermic success with hypothermia, particularly in Europe at the high altitudes in the Alps and such. Now, one of the main reasons that made this a viable therapy was technology. What you see is about the size of the palm of your hand on the bottom. That's a pump, a plastic pump that's magnetic, can spin 4,000 RPMs and pump all of your blood. And the top is just the device that spins it, the magnet that spins it. And then as far as oxygenators go, on the top, we have what we use for years and years and years and still use in the operating room, and it's tolerated very, very well. It's a polypropylene oxygenator. But when we started using them for ECMO, they leaked plasma in 24 to 48 hours, and the patients had huge inflammatory responses. We couldn't get patients through the procedures. And along came what's called a quadrox deoxygenator. It's polymethylpentane as a hydrocarbon that makes it, capillary tubes, membrane diffusion of gases, but it doesn't leak plasma. And this oxygenator can go for a month without even being changed out. And this changed the whole ball game for getting patient survivors on ECMO. This is primarily used in everybody. Now, the settings of how we adjust oxygen exchange and CO2 exchange is really simple. It's just 3 knobs. And it just manages how much flow you have through your capillary membranes, and it's managed at the bedside by the ECMO specialists. This is what our initial setups used. And it looks like what we see in the operating room for a heart-lung machine in terms of equipment. And it sits by the bedside, and it's managed by ECMO specialists and perfusionists. Now, this is what we switch to now. The actual cart looks bigger because there's a heater cooler on the bottom, but the upper right, what you see that's about the size of the body of a chainsaw and about as heavy is the pump oxygenator. The oxygenator is now swedged into the pump, so it's a click of a disposable right into the pump head, and you can actually put it between the patient's legs to transport them from the OR. Very user-friendly, very simple to get on a helicopter to go pick somebody up, put the patient on ECMO, and bring them back with this device. This is primarily what has really changed the lay of the land. In fact, if you get online, you can look and see a mobile ECMO cannulation unit cannulating the patient on the ground with the pyramid of the Louvre Museum in France in the background. Patient arrested while going to the Louvre, got put on ECMO as an outpatient on the floor of Paris and transferred to an ECMO center. So this is what's made those kinds of capabilities possible. Now, so the primary circuits are the cannulas, which are pipes about as big around as one of your fingers, and the centrifugal pump, the artificial lung. Then you need a heat exchanger to keep the patient cool, because as you run blood through tubing, it cools down. So you need to keep the patient warm. I misspoke. And then you have outflow cannulas and different configurations depending on where you're taking the blood and where you're putting it back in, whether it's veno-arterial, veno-venous just for the lungs, or we can even configure it where we put the blood, the outflow blood into the pulmonary artery and bypass the right ventricle. So it becomes a right ventricular assist device and an artificial lung. So kind of a combination, if you will. So this is what central cannulation looks like. These are those 4 tubes. One's a chest tube, but 3 of them are drainage tubes or infusion tubes coming out of the heart at the bottom there. you see black blood coming out, and then on the right-hand side, there's red blood going in. This is a little more complicated because on the left, you see two outflow cannulas wide into an outflow, and one of them's red and one of them's darker. That's because we actually have a vent in the left ventricle to decompress the left ventricle to keep it empty while the heart recovers in this configuration. So it's the cannulations are complex. They do require somebody who's experienced in this to do it, particularly central, because you have to put them in you actually put them in the heart, like the X's on the left mark where the cannulas go in. The white X's being venous drainage, the red X meaning where you put black blood back in the aorta to bypass the heart and the lungs with this configuration. Peripheral is much easier. Peripheral cannulation you can do if you use both femoral veins. You can do VV, like on the bottom. If you use a femoral vein and a femoral artery, you can do VA, and you can do it at the bedside, as you can see I'm doing in the top left picture. We're actually at the patient's bedside with a few Gawkers in the background, and we're cannulating a patient for ECMO here. Oftentimes the patients can't be moved, and you must cannulate them this way, because if you move them, they're too tenuous to move and they lose their oxygenation in the process of moving. Now I'm going to talk a little bit, it's a little bit above the scope of this lecture, but I'm going to talk a little bit about a few basic principles of both veno-arterial ECMO, which bypasses the heart and the lungs first, and then veno-venous. Veno-arterial really provides almost complete support for the lung. It provides complete support for the lungs and almost complete support for the heart. There's some blood, these pumps can't manage the total cardiac output of a big person, so which would be maybe 6 to 7 liters a minute. So it can manage 4 to 5 liters a minute. So 2 liters of that blood still goes through the patient's heart and lungs. So the total cardiac output ends up being the ECMO flow plus the patient's own cardiac output. And then, of course, ECMO flow is non-pulsatile. So oftentimes the majority of these pulses go away. So the patient has no arterial pulse. And that's something to get used to for nurses at the bedside. Of course, high afterload, high arterial pressures decrease your ECMO flow because the ECMO pump has to pump against it. And wide pulse pressures mean that you have low ECMO flow and too much native cardiac output. Narrow pressures mean your ECMO flow is more appropriate and you have lower native cardiac output. On VA ECMO, the heart is partially decompressed and you still have some flow through the left atrium. Now, one very important caveat that we always have to watch is LV distension can occur if you have very poor left ventricular contractility. So you must maintain that contractility to keep that LV empty and allow it to recover, and to keep the aortic valve from opening to avoid distension of the LV. So we keep these patients on low levels of inotropes. We monitor these patients with Dr. Chadi's group with frequent echoes, most often transthoracic, but occasionally transesophageal to assess that LV, that left ventricle. And we have other means of multidisciplinary means of decompressing the left ventricle. We can take the patient to the cath lab and let Dr. Al-Reyes put in an Impella, which is a left ventricular assist device to keep that left ventricle empty while we support the patient while the left heart recovers. We can also cannulate centrally, like you saw in that earlier patient, where there's a right superior pulmonary vein catheter into the left ventricle to decompress the left ventricle. Now, there's some deleterious effects that the body has to suffer while they're on VA ECMO. One of them is the kidneys don't work well with non-pulsatile blood flow. So we often lose kidneys and have to put them on dialysis. High left ventricular afterload does not help a failing ventricle recover. So often we have to do an extra cannula in the ventricle to decompress it. There's also a potential for direct arterial emboli, like air that inadvertently gets put into the ECMO circuit that can cause stroke. There's also, if you're cannulated from the groin, you can imagine if black blood is running through the heart and red blood's going up from the groin, somewhere the two meet, And sometimes you have what's called a north-south syndrome, where you don't get enough oxygenated blood going from the brain, and we have to manage those situations. So you have lower coronary artery and brain oxygenation because of that. And this can become a significant problem where we have to address by adding an additional venous return cannula to oxygenate the venous side, so the blood going through the heart that comes out and goes first down the coronary, second up the head, has some oxygenation in it to keep the brain and the heart alive through all this. You can also have leg ischemia if you don't put a cannula in south from the femoral vessel, because these cannulas are so big that they occlude the femoral vessel and there'll be no flow to the leg. So we're very careful to make sure we have antegrade flow with a separate cannula coming off the pump down the leg to keep the leg alive. We keep very close monitoring of the distal pulses of the legs and the compartment pressures if needs be. This is what happens when the left ventricle can be still and there's no ejection in the aortic valve. You see there where my cursor is, this is blood clot in the aorta. This is a huge blood clot filling the entire aorta. You can imagine what that does. It stops all blood flow to the coronaries, and it stops blood flow, any future possibility of recovery. So this is to be avoided. This patient didn't survive. We avoid this by anticoagulation. And like I say, we maintain ventricular ejection with inotropes, balloon pumps, and impellers sometimes. This is even worse. This is where the LV was so bad that it completely filled with clot. There's no way out of this situation. So these are some of the things that can happen on ECMO, why we need vigilance of these patients. This is an example, like I said before, very important cannula this. This is a cannula that goes past this arterial cannula down the leg to keep this leg alive while these cannulas are plugging up the vessels to the leg. Now, some of the basic principles of veno-venous ECMO. It's really important that you have a heart that works, because you're providing no cardiac support. You're taking blood out of the right side, putting it back in the right side for no net negative gain, and all you're doing is oxygenating it. Now, sometimes there's indirect improvement of cardiac function, and that's an important point that you learn with experience. That will frequently be called to a patient with primary respiratory failure, and they're on huge amount of inotropes, like massive doses. Before, we used to put them on VA ECMO with all the deleterious problems that can happen with it. Now we realize that all the heart needs to work better is oxygen. So once we oxygenate these patients, oftentimes it's very frequent that we can ratchet down the inotropes very, very quickly. Sometimes within 15 minutes, we can go from 0.4 of levofed down to 0.05 of levofed and drop it by nearly 10-fold to 100-fold. And so frequently now, I would say very infrequently, we end up putting patients on VA ECMO that long-term only need VV. Now, one of the things we have to watch is that the right ventricle, like I said before, there's no positive improvement with cardiac output other than giving the heart more oxygen. So we have to really watch the right ventricle and how that's working. And the other thing is sometimes the compliance through the lung is really poor. So your function through the lungs is really poor, and we have to switch to it's really hard to drive that blood through the lungs. And we have to switch to a right ventricular assist device in combination with ECMO to support the right heart. Now, these oxygenators, as good as they are not as good as a native lung. So saturations are never as good. And we frequently have to tolerate lesser saturations. It's something for nurses at the bedside to get used to. Some veno-venous ECMO, much easier to cannulate. You're working with the venous side, not arterial pressures, and you're not occluding a leg to put cannulas in. So much easier to cannulate. Much lower risk of bleeding with a lower pressure system. Effectively, no risk of arterial embolization unless you have a patent foramen ovale and you have paradoxical emboli. You also, because you're putting oxygenated blood back in the right side, which is not natural, your lung beds are oxygenated, and therefore you get better coronary oxygenation because all the blood coming out of the heart is fully oxygenated. You also preserve pulsatile blood flow to the kidneys. Your CVPs are accurate because where their CVPs are not in veno-arterial ECMO, because you're draining as much blood as you can out of the right side. The CVPs here, they're a net even because what you take out, you put in. And the saturations, as you follow them, they improve as the patient's lung function improves and contributes to the ability to oxygenate. Now, the biggest pitfall to VV ECMO is something we call recirculation. And because it's interesting, I'm going to present just one slide about it. There's some signs that we look forward that I'm not going to enumerate, but this is just a cartoon showing what can happen with your cannulas. On the left side, we have an ideal situation. We have the blood that's being infused as number 13 directly being dumped into the tricuspid valve and not mixing with the blood that's going to the oxygenator in number 12. In the middle, you can see a horrible situation. All the blood that's going back in the patient is coming out the outflow cannula to the pump. This is virtually 100% recirculation. You're not doing the patient any good. You have a cannula above, a cannula below, but you're not doing anything, but your numbers look great in terms of your post-oxygenator saturations. And on the right side's a mix where the cannulas are a little misplaced and you're not oxygenating as well. The other night, I got a phone call at 2 a.m. They said the patient's sats weren't very good. I said, I think we have too much mixing going on. I said, pull this one cannula back 5 centimeters. My suggestion was met with disbelief that that could possibly have any bearing. I get a text back an hour later. We pulled the cannula back 5 centimeters. The saturations went up 10 percentage points. So these are things that experience tends to teach you how to manipulate the system to get better results. Now we have another thing that came on the line that's just brilliant. This is called an Avalon cannula. It's a 2-lumen cannula that has drainage holes and it has an infusion hole. And the one infusion hole that they put, if you position it correctly, it dumps all the oxygenated blood right through the tricuspid valve through the heart. So you get very, very little mixing, extremely efficient cannula. And we use this. The other thing, it's one cannula that rather than 2. And so frequently we put under duress, we put the cannulas in the groins at the bedside to get the patient stable. Then the next day or two, we take them to the operating room and under fluoroscopy, we put this Avalon cannula in the appropriate place. We confirm it with transesophageal echo, and then it gets the cannulas out of the groin. So we actually, in patients that are neurologically intact, we can sometimes extubate them and we can actually get them mobile and walking while they're on VV ECMO. This is another cannula, which is a kind of an offshoot of the cannula I just presented. This is called a Protect Duo cannula. This is a brilliant cannula that actually snakes through the heart and puts the outflow into the pulmonary artery. So it sucks the blood out of the right atrium, oxygenates it, and through a separate lumen puts it back in the pulmonary artery. So it completely decompresses the right ventricle and acts like a right ventricular assist device and an ECMO, VV ECMO system. And in this way, we can treat patients with pulmonary hypertension where their right hearts start to fail because they may have a pneumonia so bad that the compliance of the vessels through the lungs is low, and you can't push the blood through as well, and you need a pump to do it that's more than their right heart. So we frequently use this in those kinds of patients. This requires fluoroscopy to place, but it's a brilliant cannula. So why do these patients die? Well, they die because their organs weren't recoverable. Refractory heart failure, too far, too little, too late. Refractory lung failure. They couldn't recover from their COVID pneumonia. They have multiple organ failure that they couldn't recover from the other organs that failed alongside their heart and their lungs. Kidneys, liver, hematological organ system. They have strokes. They can bleed in their head. We saw a lot of bleeds in the head with COVID-19. We really don't understand why these patients had a propensity to bleed like they did. With cannulas the size of your fingers in patients' arteries, they can get bacterial sepsis. When you're running blood through tubing, the blood wasn't meant to be run through tubing, and it gets coated on the tubing, and they can get DIC and bleed. They also can get ischemia to their bowels from low cardiac output and low perfusion, just like other sick or patients with multi-organ system failure. Now, what about program development? This is a slide that's a little bit about my vision when I was a resident. This was 2 weeks before the end of my fellowship at Hopkins. And I keep case notes of my patients. And I wrote about a 32-year-old woman. And the case was ECMO placement. She was 21 weeks pregnant. You see what she had. She was in full arrest with cardiopulmonary resuscitation. She was resuscitated on bypass. We tried a VAD. She had pulmonary failure. She required ECMO. And then my notes cryptically say, she went the way of all ECMOs, meaning she died. This is what it looked like back then in 1998. This is back when Bob Bartlett was still persisting at the University of Michigan to try to get survivors of these kinds of patients. So it's different now, and I've given you the lay of the land. Well, my first ECMO program I started happened to be in Texas, and we were developing a large tertiary care program with very complex patients. In our initial attempts at post-cardiotomy salvage, they all died. So I noted a few things. Decisions were all made under duress. We had no organization. We didn't have a support staff. We had overworked personnel, and we had a completely unprepared blood bank. So I saw this negative feedback being propagated persistently. People don't want to take care of patients if there's no chance of survival. So we hypothesized that if we could prospectively have an organized approach to salvage a percentage of these patients, like some of those series I showed you earlier with Nick Spandera at the Cleveland Clinic and Fred Moore at Leipzig, we had all these other centers, but all of those you see, like a center for aortic disease or an acute coronary syndrome, all those patients have end-stage patients, and some of them are recoverable. So we needed an ECMO program. So we wrote a book about guidelines. We developed a business plan, and we had marketing materials. Then we set up assignments, surgical and medical directors for daily decision-making, perfusionists to direct the day-to-day maintenance of equipment and manage ECMO in the OR, specialists that we trained up, and nursing specialists that would take care of these patients at the bedside. And we've now done this same thing at the DMC, this exact same thing. Maybe a little bit different, but primarily the same. And we train them. We had in-hospital ECMO courses. We have our specialists in training. They have to master the guidelines of ECMO. They have to attend the team courses. They have to have intraoperative perfusion time. They have to master a wet lab that our chief of perfusion runs. And then they're proctored at bedside ECMO management. And the same for the nurses that take part in the care of these patients. This is what it looks like. That's what I said before. It's way more than one person. It's a team. You see a scrub nurse setting up the table. You see the perfusionist leaning against the machine in the back. And you see a perfusionist that's kind of coordinating the effort at the foot of the bed. This is what a travel unit looks like. A surgeon on the left, that's actually me, a lot younger. And then we had a coordinator that would get privileges at the other hospital for us to have privileges to go and operate on their patient in the other hospital. In the middle is a scrub nurse, then an ICU nurse that manages the drips, and then the chief of perfusion that goes along to manage the pump. And this is what it looks like in the back of an ambulance. And this is what it looks like in a fixed wing Citation jet, bringing a patient back. Barely enough room to work, but the patient lived. This patient lived and went home. So it's all worth it for that patient. We actually had a flow diagram too. So when we went to pick up patients, not everybody got put on ECMO because it's expensive. and when you're going to another hospital. So unfortunately, we had a diagram that required approval that where we would get to a yes on the right, that we could go pick up our patients. We had daily rounds and protocol-driven monitoring. And this is what we do with our program here at the DMC. We have protocol driven monitoring where we get daily chest x-rays and routine labs and coagulation parameters. And we measure pre and post membrane oxygen, ABGs, and the parameters are documented every hour. We check the circuit with a flashlight to see if there's any clot building up in the corners of the oxygenators. And we use CT scans and TEE frequently to assess the other organ systems that are affected. We monitor whether or not they be on heparin, when they're on heparin, what their platelet counts are, what their saturations are, and what their pressures are. And we pay attention to a lot of detail, like the changes in oxygenation requirements may mean that they're septic. Change in mental status may be that something's going on in their head. What's going on with their temperature, their vascular resistance, their hematocrit, are they bleeding internally? What's their white count? Are they coagulopathic, and are they still making urine? And I've kept a couple slides just looking at some of the little things. They're not in any particular order, but some of the things that we've learned. We've learned to extubate early, to try to allow these VV ECMO patients that just have primary lung problems to participate in their care. If we can't extubate them, we do an early tracheostomy so that they don't have an ET tube through their vocal cords, which drives them crazy and requires them to be heavily sedated. We reduce ventilator settings to avoid barotrauma. I mentioned earlier, we maintain inotropes to keep their hearts empty. We hemofiltrate their blood to maintain their volume status when their kidneys can't. And we use fluoroscopy to be safe about cannula manipulations, so we don't have mortalities because of errant cannula problems. We emphasize mobilization. We try to get patients to participate in the care. We move the cannula from the femoral area to the neck, where it's tolerated much more easy. And we need nutrition, so that they can heal up their injuries. We've learned that patients can survive very, very long ECMO runs. Our last 4 COVID patients were all survivors, and all 4 were on ECMO more than 100 days. That's over 3 months until they could clear their COVID infection. We've also learned that very short runs can be life-saving, like a very short run of 1 day to warm a hypothermic patient up, or a drowning patient that needed to be resuscitated for a couple days. Sepsis can be treated despite having these big cannulas in. We've learned that. We've learned that if the patient starts having Coca-Cola type urine because they have hemolysis, that all you have to do is change the circuit. It's a connector that's causing hemolysis or something. We've learned that particularly with VV ECMO, you can get away without heparin if a patient's bleeding. That was something that took us a long time to learn. We were so worried the pumps would clot, but as long as the pump has good flow, they don't clot above 2 liters per minute. So we've learned you can get away from the heparin. That's been life-saving for patients that have GI bleeds and things like that. So if you have bleeding, we stop the heparin. We've also learned that you don't have to terminate a patient just because they're now on dialysis on ECMO. If they're young, the kidneys frequently come back. So that does not have to be a terminal decision to terminate a patient. And that's important to tell families, because many families say, the kidneys are gone, we don't want to persist. So that's something we've learned over time. Individual patient successes really serve to unify the team and validate a program. I'm just going to flash through a couple successes. This is one. This is another one. This is another one. 2 ECMO runs on him. Sherry Alvarado will remember all these patients very, very well. This is another one. Young woman, endocarditis, 4 kids at home. She was pregnant. She lost the baby, but she lived. And she came back to thank the the helicopter crew that brought her in. So how do we do? Well, we still do very similar to what you saw Bob Bartlett's what Bob Bartlett showed in his series. And sum of survival, this is the first program I started. You see a few years here. And the most important number, survival to discharge, 38%, 41, 29, probably pushed it too hard. And then the best year, 43, 51% survival to discharge home. This doesn't matter so much. A lot of programs will report off ECMO, but it doesn't really matter if you don't go home. So the real number to look for is what was the survival to discharge. Now, ECMO is very, very common, very popular. These are the centers around the world. They're everywhere. So this is therapy that's here to stay. And here's centers by the year in the United States. The last couple of years, once we got the pump oxygen, the oxygenators that really work long-term have really come up. And you can see here, this is a report from 2014, but it's the last one I could get my hands on, which is really solid data. And we see survival in adults to discharge for respiratory ECMO is now above 50%. For cardiac, still 40% range. Surprisingly, this number of patients that are getting CPR prior to ECMO, this number is rising. So we need to start considering that to be more aggressive with young patients that arrest, say on the little league field, like they're doing in Europe when they actually send people out to cannulate people in the field. So a slide to show how we did with COVID. This is ELSO registry with 1,000 patients that got ECMO for COVID. You see here, here's the deaths. Here's the patients that are kind of in between, caught in limbo, either at an LTAC or not necessarily discharged, but about 40% survival across the board. So that's how we did with COVID, which if you say all 1,000 would have died, which I think is a fair assumption, 350 lived. So I think, you know, this was how we impacted the COVID for these end stage patients. Now we were very selective. We did young patients. We did not do patients with high BMIs. So we were selective with our group, but this is across the country. Now this is a group that we all looked at. None of us could match their numbers, but this is Christchurch from Chicago. They published it as an abstract, as a letter to the editor, actually. They had a 73% survival for discharge in early ECMO back in March of 2020. And they presented 40 patients, and up here you see 73% survivor. So there were groups that really did well with this disease. Now, they probably were a little more selective. Maybe some of these patients would have survived without ECMO, but we really did have a nationwide support of ECMO for COVID, and it was really important for a lot of people. Now, we have some data from our own institution here looking at mortality rates, and let me just eliminate this. On the right-hand side, you see what our mortality rates are. Now you see the majority of these were COVID patients, and we were about the same as the national average, 40% survival. If they didn't have COVID and they were put on for another pulmonary problem, it was better. It was around 60%. For cardiac, we do quite well, 50%. And the average number of days, 18 days of vigilance for our patients on ECMO in the year 2021, counting 36 patients. And these are some of the things that happen to our patients. These are the things we fight. This is just a list of the organism names of patients that got super infected with other resistant bacteria while they were on ECMO that we had to get them through these infections. And these are just a list of some of the complications like oxygen changeouts, 10 of them, mechanical cannulation problems 2, pump failure 2, pneumothorax requiring treatments 8. This is just a laundry list of the things that you deal with patients on ECMO. So to conclude, I would say that building a successful ECMO program requires a protocol-driven effort, for sure. and it's a team approach. Success depends on avoidance of a myriad of complications on a daily basis. But at the end of it all, nearly 50% survival to discharge is achievable. The ultimate question overall is the cost worth it? But I would argue that for the patients that go home and are looking at blue sky and not pushing up daisies, it's worth it for them. Thank you very much. That's a different one, but it's the same thing. They're in a subway station.
On the right side.
On the right. Oh, that other one is in an art museum. That may well be a different one. The one I'm talking about is outside the Louvre, where you see the pyramid in the background. Right. But this is what the European transfer systems are doing. We're not there in the United States yet. To my knowledge, we do not have any programs which are sending out specialists that have the ability to cannulate in the field.
Right. There's a question from the audience about the cost per day for ECMO for these patients.
$40,000 a day.
That's the hospital cost, right?
Roughly. If you look at also, there's a publication out that I didn't show the slide because I didn't want it to be a talk on cost, that shows the average cost were $344,000 per patient. Now, when you compare that to, say, heart transplant or lung transplant, it's less. It's less. So the therapy is along the lines of that. Now, that's talking about an average 18-day run. It's not talking about 100 days on ECMO.
Yeah. So the other thing is you show beautiful data, Dr. Zehr, for the outcome of ECMO, especially when it is utilized early upstream. So just a few comments for people who are dealing with these sick patients, when they should pull the trigger for ECMO.
Well, I still stick by ECMO has so many complications. Now, we should pull the trigger much earlier for VV, much earlier. The survival's 20 percentage points different across the nation. So very early in status asthmaticus, very early. We have several tragedies at the DMC where the body survived, but the brain did not.
Yeah. And that's a signal of delay in getting the patient to the ECMO, or the prognosis was bad from the beginning?
The prognosis is bad from the beginning, but the brain cannot survive no oxygen for very long. Right. And so you have to get oxygen back to the brain. So in status asthmaticus, we should not wait. If there's a failure to brake, the ECMO should be called early, because we can always discontinue it if the lungs come back quick. And I have, last year in the last 2 years, I took care of 2 patients, both one teenager, one in the low 20s, both survived ECMO, but their brains did not. And it's a big tragedy. So in VV ECMO earlier as opposed to later. VA ECMO, I would still say you need to have a better than 50% chance of not making it with conventional therapy.
Nice. I was told by one of the audience that the chat box is not working. Please use the Q&A box for questions. As we move along, what is the challenges with vascular access? I know especially in smaller body habitus, there will be a barrier for putting a large cannula. How do you overcome this obstacle?
Well, the perfusionist will tell you what he can pump through what size cannula, what bore cannula, but cardiac surgeons have a pretty good idea of what you can pump because we pump every day in the operating room that we operate. So the perfusionist tells you what the minimum cannula they can use. So that's particularly good for the groins. And of course, shorter cannulas have less resistance. So a short, smaller cannula is much better than a big, longer cannula. So the perfusionist will let you know that. In the legs, for us, it doesn't really matter as long as we can get the cannula in, because we always put a catheter south, always. I've lost too many legs in those situations. And, you're familiar too, in the old days of the balloon pump where it was 14 French, where we actually lost legs putting balloon pumps in. Well, now we don't anymore because the caliper is so much smaller, but these cannulas are big. So that's a real issue. Centrally, of course, it doesn't matter what size cannulas are. The biggest problem with cannulas are positioning, positioning VV so you don't get recirculation, and that's just experience to know where they go. And then whether or not you have to add cannulas, when to pull the trigger on that, whether or not your Harlequin syndrome or your, what, if you want to call it that, or your north-south syndrome is so bad that you're not getting the brain oxygenated to keep it alive. And we've seen that too, where you have to add an upstream cannula to make sure that you, or a venous cannula to put arterial blood in the venous side, so you make sure you're oxygenating your heart and your head.
Last question, Dr. Zehr. What criteria must be met before you consider ECMO? Kind of covered it over the course of the presentation, but just kind of big bullets.
Well, I mean, cardiopulmonary failure, where the patient is eminently going to pass away, but you think that organ system has a potential to recover. That's the easiest way to look at it. So if a person has a big MI, but there's enough recoverable myocardium and they're in shock, if your impella isn't enough, then you need ECMO. In a patient with pulmonary disease where you cannot conventionally oxygenate them without 100% FiO2 and high PEEPs, and you're still not oxygenating them well, then and it's a reversible process, those patients for sure. So it's really just end-stage pulmonary, end-stage cardiac disease, which is reversible. That's the important point. Now, if it's not reversible, there's plenty of people being put on ECMO that are going to end up with a lung transplant or a plant for a heart transplant, but that's kind of beyond the scope of this.
Right. And I remember on January 1st, 2022, you walked in and you decannulated. I remember like 3 patients.
That was a good day.
That was a good day, and all lived, all discharged. So you can add to the glossary.
That was a good New Year's present for those 3 patients. It was just what Chadi's referring to. It was a random day. I was rounding on New Year's Day in the morning, and it wasn't all of our ECMO patients, but 3 of them were ready to decannulate that same morning. We went decannulate. It was a happy day.
Yeah. We have one more minute. Question came. What is the quality of life for ECMO survivor?
Well, the ones that are standing there next to us with their photos being taken, their quality is pretty good. So I would say the important bullet point is that when you're looking at an ECMO system, you need to look at what their survivability to discharge is, because a patient that's discharged home usually has a good quality of life. Otherwise, they're not going home. So it's that gray area in between where occasionally they'll say they're getting patients off ECMO rate is 65, 70%. Well, maybe 20 of those lingered at a nursing home the rest of their life. So the really important point is, so of the patients we put on ECMO in our program at the DMC, 40% end up with a good quality of life. I think that's a fair statement.
Absolutely. Well, with no further ado, Dr. Zehr, thank you again for sharing a wonderful experience, as well as putting a successful program at Detroit Medical Center with your team, and the great success stories that you mentioned, as well as sharing the criteria for it. I just want to remind the audience also, this is a CME activity for 1 hour. You're going to receive a survey tomorrow. Please indicate what went good, what went bad, what topic you would like to hear, and your feedback is very important for us. These videos and others, or these webinars and others, are recorded, so they're going to be posted within 1 to 2 weeks on our YouTube channel. If you feel this is a good resource for your nurses, nurse practitioner, or physicians and referring physician to learn about ECMO, I think this lecture is a standard of care, as well as a gold standard, can be presented to a different level of healthcare provider to understand the history as well as the indication. Finally, this is the number for any cardiac emergency, including ECMO referrals, to call 313-578-6767 for any ECMO referrals. With no further ado, again, thanks, Dr. Zehr, for your time. and for your expertise. And remind everybody, this is a CME activity coming to you every fourth Thursday at 7 p.m. Eastern Time. Thank you so much, Dr. Zehr.
Thank you much. Have a great evening, everybody.
Thank you. Thanks to Sherry Alvarado as well and Elise Bennett for putting this together. I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.